show. I'm delighted that so many of you could join us today. I'm very excited about this topic. In fact, there have been, in the other sessions, lots of questions about medication-related issues as related to the other topics. So I'm delighted that you all could be here today. We have a wonderful presenter, and she's a presenter that I have lots of involvement with, and so she's quite an expert in this area. Her name is Dr. Patty Slatum, and she's a faculty member at Virginia Commonwealth University in the School of Pharmacy, and she is also a member of the Alzheimer's Commission and has lengthy experience with dementia and through her involvement with the chapters. And if you'd like to read the more extensive bio, you know that that's there on the newsletter for you. So I'm going to go ahead and turn that over to Patty, and then we will come back for our question and answer period. And we also have Judy Nelson from Senior Connections here with us today. She's the director of short-term home care, and she has been an excellent co-facilitator here to help move some of our discussion along. So I thank Judy for being here also. So without further delay, I'll turn it over to Patty.
Okay, thank you. And I am looking forward to our discussion this afternoon about a topic near and dear to my heart, which is preventing medication-related problems. And we head to our first slide. Okay, before we start talking about all the issues that can be related to medications, it's important to remember that they really are an important healthcare technology for improving our overall health and longevity. We have gained an awful lot from the advances that have been made in pharmaceuticals in preventing illness and disability in our older population. But as with many things, it's a double-edged sword. And along with these advances have also come the complications that arise when medications either aren't used appropriately or have adverse events and other things associated with them that result in problems. So this is one of my favorite quotes. Any symptom in an elderly patient should be considered a drug side effect until proven otherwise. And, of course, this is coming to us from geriatricians and folks who work with older adults quite a bit. And we see these drug side effects resulting in all sorts of issues for older adults that get unrecognized, treated as other kinds of health problems, and causing actually as much as nursing home placement that wasn't necessary because we don't deal with these very well. So that's some of the things we're going to try to talk about today. And, you know, in our pharmacy world, we define medication-related problems as an undesirable event that's experienced by a patient. And it could involve, or even just be suspected to involve, drug therapy. And it could either actually or potentially interfere with the desired outcome for the patient. So it's something, negative outcome, that is associated in some way with medications, I think is probably the simplest way. So this is a very broad definition of what we mean by a problem. And there are a lot of symptoms of having a problem with medications. This can be things like changes in speech, confusion, depression, insomnia. And every time I talk to a group about these symptoms, what I hear back is, oh, well, those are often the things that we associate with aging itself or with certain chronic diseases. So that because of these types of symptoms, these problems don't always get picked up as being what they are, which is associated with the medication. And, of course, any one of these symptoms could be caused by a number of things. Medications are only one contributor. But we need to make sure that medications are considered as one of the possible contributors, I guess, when we look at them. And there are very few medications, for example, that if you look in their product labeling, actually list falls as a side effect. And yet we know that medications can contribute to as much as 20% of falls that are experienced by an older adult can be linked to a medication problem. And yet we don't see that listed as a side effect of a drug. So they just get missed, I think. And there are a lot of types of medication-related problems that we can also consider. And when we think about the types, then it leads us to talking about solutions. So one thing that doesn't necessarily come to mind right away when you think about medication problems is sometimes the problem is not having a medication that you need. And
if this bothers you, let me know.
And here I'm thinking of preventive health care and other things that we sometimes don't initiate, and by not initiating them, we run into a problem. Calcium and vitamin D for osteoporosis prevention or treatment is one example of that. Not receiving appropriate therapy for depressive symptoms or pain is another example. So here we're really talking about a medical condition that requires therapy, but nothing has been initiated. It can also be taking a medication that's just unnecessary considering what the present condition is. Sometimes medications get started for a symptom and they get continued then forevermore. Even if that symptom may have long ago resolved, this happens when an individual maybe has a seizure and then 20 years have gone by and there haven't been any more, but the medication for some reason has still persisted. It happens sometimes with medications for GI complaints, where there were some symptoms at one time, but we really have no idea 5 years down the road whether those symptoms are still an issue. The person's not experiencing them, but they've also been taking a medication for an awfully long time. Sometimes it's the wrong drug for the patient's medical condition or their age. And this is where medications being used to treat one condition can worsen another, or that aren't handled very well by older adults, either because of the way they get out of the body, they tend to accumulate, or because of changes in the physiology with aging that make the individual much more sensitive to the side effects of the medication. Sometimes we give the correct drug, but the dose is too low. And this really comes because we're afraid of harming older people. When I see this in practice, it's, take a quarter of a tablet of something, and really there's almost no chance that quarter tablet will provide a lot of benefit, but we're so afraid we might rock the boat that we give a dose that's really too low to cause an effect. And so what we see is just really an unnecessary expense. It's not enough medication to cause a benefit, and it's being paid for by someone. Another thing that older adults run into is the opposite problem, where because their age is not taken into account when the dose is prescribed, then it's the correct drug, but the dose is just too high. And this can result in a higher risk of experiencing side effects when the dose is too high. Of course, adverse drug reactions or drug interactions are also medication-related problems, and older adults are at higher risk for having these because they have more chronic health conditions and because of taking multiple drugs, more opportunity for a drug interaction to occur. And we also have the issues surrounding not taking medications correctly. And this isn't always because the patient isn't understanding what the instructions are. It can be that we're very unclear in what we're asking people to do in the instructions we provide. And many things, sometimes it's cost, the affordability or access to medications contributes to not taking drugs correctly. Sometimes it's adverse events that cause people to stop taking medications when there may have been other solutions like decreasing the dose that may have solved that problem. And so always makes me cringe a little bit when I see this patient not taking drug correctly implies that it's the patient's problem. But oftentimes it's really our health system's problem in how we kind of communicate the best way to utilize the medication and our communication in dealing with problems that arise. So we'll talk more about that when we talk about solutions to the problems. So there's a lot of types of medication-related problems that can occur, and there's reasons that older adults are at greater risk. We already talked about the fact that multiple chronic diseases that tend to occur at increasing rates as we age get then treated with multiple medications. And I saw a great example in the literature where they had a hypothetical 75-year-old woman who had 5 chronic conditions, and if you applied with all of the practice guidelines that are in place for caring for those conditions, she'd be taking medications all day long to actually to sort of comply with each individual disease state. But we know that people are not just a collection of disease states. We have this whole picture that we need to be looking at. And so whether or not all of those multiple medications are the most appropriate thing needs some attention. And when we get multiple chronic diseases and multiple medications, we often are in the position of having multiple prescribers. And this really gets at the idea of how coordinated our care really is. And because it's not a very coordinated system, when you get right down to it, communication among prescribers and with the patient and with other members of the healthcare team, pharmacists, nurses, many people that may be involved with trying to manage the care for an older person, their family members, their informal caregivers. There's just a lot of people that get involved in trying to manage this, and our communication among each other could be better. And when this is the kind of situation that causes unintended drug interactions, duplications of therapy, and other examples of medication problems because of our uncoordinated communication. Aging itself, physiologic changes that are associated with aging, make older adults more vulnerable to having adverse drug events and other medication-related problems. And why this is that the major ways that drugs get out of the body, whether it be through the kidneys or through metabolism in the liver, these processes tend to be less efficient as we age, so drugs tend to accumulate, have higher concentrations in the body, and those higher concentrations make it more likely of having an adverse drug event. And when you add multiple medications together, then this risk even becomes higher of accumulation of drugs in the system. So aging itself increases the risk. We also suffer from this problem of not always having the best evidence of what the most appropriate thing to do with medications is when you look at older adults, because they're underrepresented in the clinical research that goes on. One great example that was a study that was done in the Canadian health system looked at Aricept for Alzheimer's disease, and they looked at who was it that was studied in the clinical trials, what criteria did you have to meet to be in the clinical studies, and they compared that to the characteristics of individuals who receive Aricept through the Canadian health system. And they found that over half of the people who take Aricept wouldn't have qualified to be in the clinical trials that looked at its efficacy and its side effects. So what do we really know about those maybe more complicated patients that weren't in the clinical trials? We really sometimes lack the evidence of what's the best thing to do.
They're talking about Aricept.
And we also have a shortage of professionals still that have specific training to work with older adults and who have these kinds of issues at the front of their mind. And I think this is an area where we can also make improvements in making sure that the word gets out about the best practices for care of older adults. So that's just some of the reasons that older adults are at greater risk, but we can see that there are quite a few of them, and they may be different from individual to individual, how significant each of these is. And there are also reasons why we haven't done a very good job, I think, in addressing these medication-related problems when they occur. One reason that I often hear is that, well, I've been taking this medication for a long time. How could it be associated with the problem I'm having now? And when that sort of rationale comes into play, what it's not considering is the fact that our bodies aren't the same over time as they were. when we started taking a medication. So a medication that's been taken for 5 years or 10 years, our response to that medication as our body ages will not be the same at age 65 as it might be at age 75. And so something that has been used for a long time without a problem can begin to result in a problem. And so that needs to be taken into account in evaluating the drug therapy. It doesn't have to be a new medication that's associated with a problem. Another reason is that it's hard sometimes to identify within the healthcare system who will be responsible for making sure that the problem gets resolved, because one prescriber is not necessarily the one prescribing all of the medications. So if there's a drug interaction between a medication prescribed by the primary care physician and by a cardiologist, which one of them is to be responsible for correcting it? This oftentimes is not a simple negotiation. And so you may have a pharmacist involved in that communication. There may be family members involved. And which doctor's medication is the one that needs to be fixed or corrected to prevent the drug interaction? Not always as straightforward as it might seem to solve. So uncoordinated healthcare is another reason why medication-related problems don't get addressed. Sometimes we're worried that the risk of stopping medications is greater than the benefit that might be achieved by doing it. And in general, I think we're fairly risk-averse. We don't want to cause a problem. We don't want to rock the boat. Will stopping the medication result in more problems than if we're not really sure the medication is what's causing the problem to start with? And I find that oftentimes this is the case. It can be the patient themselves, it can be the caregivers, it can be the practitioners in the health system are just really nervous about rocking the boat, even though there may be a problem that could be helped by stopping or reducing the dose of a medication. I think there's also this idea that older adults won't change what they're doing with their medications. And I think this is really a stereotype that about older adults that really needs to be critically looked at why we have it, because there are some patients who resist changes in their drug therapy. And this may be because they're dependent on it, either psychologically or physically, but you can be dependent on a medication. But just because a person is of advanced years does not mean that they cannot change their therapy if they understand the benefits that might be achieved by doing that, and they have concerned healthcare professionals to work with them and family members to work with them in achieving this. And so I will often hear, well, there's no point in doing that because the patient's not going to go along with it. Or their family members are not going to go along with it, even if you think this might prevent them from falling or address a problem that's at hand. So I just like to encourage the idea of not assuming that patients won't change things just because of their age. And of course, when we talked about the symptoms of medication-related problems, a lot of them are not the typical side effect that you see listed on a package insert or a patient leaflet. They're things like falls or confusion, and they get mistaken for many other things besides a drug problem. So sometimes they're not getting addressed because we don't really believe that medications are a contributor to what's going on. It's not what we would normally expect to see in a younger adult. So it's a little bit of an atypical presentation. Confusion is one where realizing that a medication might be causing that frequently gets overlooked. So there's lots of reasons why they're not getting addressed. And that moves us to talking about what are some of the things that we can do to prevent them. And number one, I think, in all of this is improving the communication with healthcare providers and between healthcare providers and patients and caregivers about medications. And really what I mean here is making sure that all the prescribers really know the medications that are currently being used at home. Making sure that questions about medications are getting answered, that we know why the medication has been prescribed. We know what we're supposed to expect to see as a result of taking the medication. I talk to a lot of patients that get a new prescription, and what I find out is that they may have had a symptom, but they're not really sure what this medication could be expected to do for them. And being a little clearer about all of that in our communication, I think, would help to reduce the risk of running into some of these medication-related problems. I think it's also really important to designate a medication manager. And this really means a prescriber that can take, or a physician that will take responsibility for making these necessary changes and adjustments that need to be done over time, and will be able to take a critical look at the entire drug regimen, not just the medications that they themselves are prescribing. And I think many of us just assume that this is happening within the system, that somebody's managing all the medications. But often if we don't ask, it isn't really being done. So talking with personal physician about their comfort level with doing that, being the medication manager, being the person to consult, pharmacists can help to, I think, negotiate this and find out what some of the issues might be that need to be considered. But making sure that there's someone looking over the whole list, because it's very hard for us to do that on our own as a caregiver. We'd like to have a partner in that, and we need to designate who that partner is going to be. And it's very important for patients, their caregivers, to keep a good medication list of really how they're taking it, what time of the day, what dosage, keeping up with any changes that might be made in that regimen. Patients really need to become the holder of the list and take it with them wherever they go to interact with the healthcare system, because we know that there are many times, especially in transitions of care settings, where the list gets messed up. And we need to make sure that there's a good, accurate list so that decisions can be made that are considering the entire medication that's being used. That includes over-the-counter and herbal therapies, which sometimes never show up on a prescriber's list of medications unless they've specifically asked for them. But drug interactions, adverse events can all be associated with over-the-counter and herbal therapies as well as prescribed drugs. So there really needs to be a good overall list. Consulting with a doctor or pharmacist before taking over-the-counter medications or herbal supplements. Not only should they be on the list, but making sure that they may not be contributed to the problem as well. And I'll give you a good example with one of my own family members who started taking Tylenol PM because he was having difficulty sleeping. And he ended up at a doctor's appointment for some symptoms that he was experiencing that were really related to the use of the Tylenol PM, because it contains diphenhydramine or Benadryl, which is a anticholinergic medication that causes problems for a lot of older adults. Can be pretty safely taken by lots of people in different age groups, but the older we get, the less able we are to tolerate those types of medications. He was feeling actually confused in the morning, got lost in his neighborhood, thought he was developing a cognitive impairment. It turned out to be related to a medication, but it was an over-the-counter one that he really had never talked with anyone about using. He read the box in the pharmacy, bought it himself, and really never consulted with a health professional about how this might mix with his current health conditions or his other medications. So it's important to talk about those things. Also, just using common sense when using medications. Virtually every time I talk to a senior group about medications, I find out that at least someone will admit to sharing their medications with other people or using someone else's medications. And I bet if I were to ask now, almost everyone that that is on this call has some prescription that still has a few pills left that they're keeping, just in case. And this might be pain medication left over from having a tooth extraction, or the 2 antibiotic doses that you forgot to take last time, you had a bronchial infection, and those, we might need them, so we keep them. And then one of our friends gets a symptom, and we share those. spouses share medications all the time like this that they think might help the other person. And I think there's a high risk in doing this, and especially the older we get and the more things we're mixing it with. So that's one of the sort of common sense things about using medicines. And, making sure that we're following as best we can what directions that are there, and just asking when you're uncertain. It's important to obtain refills in a timely manner because when there's this lapse, sometimes a lapse of time goes on, 2 or 3 days, there's no medication because we're waiting for a refill. You go in to get it and the pharmacy has to order it. Or it's the day that the medication runs out and the can't get to the pharmacy that day for some reason. And I know this happens a lot. I hear this from some of our support group members in the Alzheimer's Association. You think you have a plan to do something that day, but there are things that can intervene. And then a day or two might go by without having the medications that are needed. So obtaining those refills in a timely manner I think, prevents that. Some medications, if you missed a day, not a big deal. Other medications can really cause some problems, almost like rebound effects if you stop them suddenly. And so it varies from medication to medication, and it's important to get advice about that if you do have to miss doses, and getting the refills on time is a way to prevent some of the problems. I also wanted to briefly talk about some of the tips for administering medications to patients that have dementia. And these are based on recommendations that the Alzheimer's Association has, but I think they actually are very good, and some of the helpline calls we get and other things really, these turn out to be some of the solutions to the problem at hand. One is to make sure that the instructions that we're giving to the patient when it's time to take medication is very clear and simple. This is your medication for such and such a health condition. You need to put it in your mouth, drink some water, and swallow it. And you might even have to do that in sequential steps. Once it's in the mouth, then say, here's the water, and then remind them to swallow it. Even simple tasks that we have to carry out, seemingly simple tasks, are not so simple when you try to divide them into all the steps it takes to do it well. And medication administration is one of those things. That gets harder and harder as a disease like dementia progresses. So trying to keep the instructions simple. I know that sometimes, and I know this happened with my own family member that had Alzheimer's disease, he began to think that the medications were poisonous. And, not giving him, if we gave him, really, this is clear instructions about what he's supposed to do and what the medicine was for, and he seemed to swallow it. But if you handed him the pills, he would look at them, he'd actually throw them, he'd put them in his pockets, all sorts of stuff besides taking it. So language can really help. It did in his case. Developing a routine surrounding medications is also a good idea for helping to make it a smooth process. And I think it's important not to assume that the patient can manage all the medications on their own. And, of course, we want to promote individuals to be as autonomous and independent as they can be. And medications is always a tricky issue. How long can someone actually continue to manage their own medications? And it sometimes gets to the point where it's a problem occurs, and that's when we realize that this isn't working. Similar to driving the car. We realize there's a problem with driving when something bad happens. It might be an accident. It might be getting lost driving. I think medications are a similarly tricky issue of knowing when someone can actually manage their own or not. At least with medications, it's important to try to use or at least go back and make sure the medications have been taken. If the patient has said that they have been, are the right number of pills in the bottle, that sort of thing. And there's lots of assistive devices that can be used to help manage medications. So keeping them organized is also a good way to help people stay more independent with them. So using some kind of specialized packaging, pill boxes, but the more of those things we use, then the more, intervention that needs to take place. Someone needs to fill the pill box. Someone needs to arrange for the specialized packaging. But these steps can come into place as the disease progresses so that the individual can remain as independent as possible related to meds. And we have to adapt medication administration over time. Medications can become increasingly difficult to swallow as Alzheimer's disease progresses, and there are many alternative dosage forms that are available for drugs. But we have to know about them. And a pharmacist is a great resource for being able to say, is this available in a liquid, or are there alternative medications that could be used that have different dosage forms? What can actually be crushed and what shouldn't be? And there's an awful lot of medications that shouldn't be crushed, and for different reasons. But that's not always obvious just by looking at the prescription vial, whether that's true of this particular medication. So always getting advice on whether crushing this medication is a good idea. And one thing that you have to take into consideration with crushing is it may be okay it doesn't alter the chemical, how much of it gets absorbed or anything like that, but what it does alter is the taste. And putting these crushed meds, sometimes getting someone to swallow them, they can taste really awful when the coating is off because it's been crushed up. It's also important to store medications safely because certainly when the patient gets confused, did I take it already or not? I know I had one instance where one of our dementia patients took their warfarin or Coumadin twice, which is a blood thinner, and ran into some problems because of that. There's some medications that doubling up the dose can be really harmful, and so we want to make sure that the medications aren't that easily accessible if the person's having trouble managing them on their own, and also that children and others in the household, pets, can't get at them. I told you my family member was hiding them, the pills. I've had clients come into our pharmacy, sit down in the chair, and pills fell out of their pocket onto the floor, just loose pills. And they're just accumulating them up. It was somebody who had cognitive impairing illness, and I guess instead of putting them in his mouth, he was putting them in his pocket. And he had a whole pocket full, so he'd probably not been taking his medications for several weeks. And they all came out onto the pharmacy floor out of his pocket. So storing them, when that kind of thing happens at home, then children or pets can pick up these pills off the floor, and it can potentially not be good for them to be eating them. So those are some of the kinds of tips that the Alzheimer's Association recommends, and I think are actually pretty good ones for dealing with some of the specific issues that come up with managing or administering medications for patients with dementia. And what I'd like to do is open it up for some questions. Everybody's been very quiet until now.
Listening, Patty. I tell you, every time I hear you, I learn something new. And, the thing that really came out to me this time was the thing, everybody says, oh, you should have a list, you should have a list. But the thing that you mentioned this time that I had never thought of, that you should also write down exactly when you take it, not just what it says on the bottle in terms of when you should take it, but when you are actually taking it.
Yes.
That's really helpful in terms of how specific we need to be about that information. And a couple of the other themes that have kind of come up across these sessions, the importance of having an informed team that you're working with. Make sure everybody knows all the all the various medications and diagnoses and so on, and also of identifying a medication manager, one person who is your spokesperson, who can help you along with this. And also helping to stamp out some more of those ageist attitudes, that just because this is going on doesn't mean that it is a normal aging process, because like you said, and I've quoted you so many times about the idea that any symptom should be considered a medication-related problem first, to look at that one. And I love the idea that of what you said in terms of people are not just a collection of disease states. And I think sometimes, particularly when we work with people who are particularly frail, and that's all we work with, we seem to become very myopic about that's the general world, and looking just at a snapshot and not considering them as whole people. So I thank you for that reminder. So that's kind of, the things that really jumped out at me, but I'd love to hear other people's questions for Dr. Sladum.
Dr. Sladum, this is Eileen Thompson from the Alzheimer's Association.
Mm-hmm.
I am just thrilled with your talk. I think it's wonderful in so many ways and extremely helpful, and I expect to be quoting you myself from time to time, if that's all right. I have several questions. My first is, how does one incorporate a pharmacist into medication management and have oversight of huge mail-order pharmacies? And as a related point that I want to mention, for example, Cross Blue Shield Federal is the largest health insurance provider in the D.C. metropolitan area. And they have started with Merck Medco. Then they went to Caremark, all within 2 years. And now, January 1st, they're reverting back to Merck Medco. So not only are these huge mail-order pharmacies, but also they're changing for a lot of people. Mm-hmm. And I think this creates a real issue, and particularly when the person is perhaps on something that requires a special authorization, which takes a long time to get, is generally good for a year and then has to be gotten again.
Well, you raise up a hugely important issue, which is that we have lots of, I'll call them almost disincentives within our health system for providing coordinated care. In other words, there's incentives to switch around pharmacies. There's incentives to use different provider groups because it's cheaper this year for me to do it this way than it was last year. You even see pharmacies, we'll give you a coupon if you change your prescriptions to us.
Yes.
Well, now there's multiple pharmacies involved. And you have distance pharmacies like mail order. Can you get answers to questions from these pharmacies? Sometimes you can, but it's hard for those pharmacies to really know you as an individual. So how do you develop these more personal and long-standing relationships with health providers, whether it be your prescribers, your pharmacist? It's really sometimes hard, but can be done to seek them out. It's finding a local pharmacy, or if your insurance is requiring you to use mail order, it's possible to hire a consultant pharmacist to do this that's separate from the dispensing of your medications. Now, I think you can expect as a standard of care that there's going to be a pharmacist at the time of dispensing who can evaluate your prescriptions for drug interactions. But that's only for the ones they know about. Right? So if there's over-the-counter medications, there's herbal products, there's medications being obtained from multiple sources, that gets hard to do. Even then, that's a piece of the oversight that might not happen.
Yes.
And so it really becomes almost like finding yourself a pharmacist case manager.
Right.
Uh-huh.
And there are increasing numbers of pharmacists who do this for a living.
That's another expense, of course.
Absolutely. Will there be reimbursement for those kinds of services through insurance in the future? I think that's part of what MTM is, the Medication Therapy Management of Medicare Part D, is supposed to accomplish.
Well, I hope so.
But I think we all are hopeful that will be true. Pharmacists too. But how it's all going to play out still remains, some of it still remains unknown. How much of that is going to be provided in a person-to-person interaction versus over the phone or it just still remains to be seen how each of the plans will formulate their MTM.
May I ask one other question? I am concerned about the administration of medications in assisted livings and nursing homes. I realize that with the special packaging it should be easier, but I have seen through personal and professional experience too often medication errors. And I don't believe that some of the medication technicians are properly trained. Their language skills leave a lot to be desired, and they don't seem to be following appropriate dosing standards. An example would be very similar to one that you gave, but within the nursing home environment, seeing a Parkinson patient with a tremendous tremor being handed the medication. And then, of course, it landed underneath the chair, not to be seen by anyone except the cleaning crew later that night. Another situation would be that I have witnessed is a person with Fosamax being given their medicine every morning at breakfast. And then, of course, having the person go through tremendous numbers of GI processes to find out what was wrong, and never even realizing that the medication was being administered improperly. And sometimes seeing that these issues are a question of the convenience of the facility rather than the actual needs of the patient or appropriate dosing.
I couldn't agree with you more about that, and we could probably talk all afternoon about examples of really bad practices that have happened in with an individual patient in a assisted living environment. And I think until we come to grips with how we can pay for our chronic care needs for older adults, we are going to be in a position where many of the folks who are administering these medications, they may get through the state training, and even that sometimes can not be very efficient or effective for an individual medication technician, right?
Yes.
But we've tried to revamp that system, and there is a system because we know there's problems. But I find in my own, I work with one assisted living facility pretty directly, and it takes constant retraining, refreshing, and when a patient comes in with a new condition, it takes a whole new education about what's necessary for that patient. For some medications, the dose being within 1 or 2 hours of the scheduled time is fine. For others, it really needs to be at the scheduled time. I have a Parkinson's patient who's at the end of the hallway, and she gets her medications almost an hour and something after the scheduled time. Well, she can't get up and dress herself until she has the medication.
Yes.
So then she gets called uncooperative and other things because the people taking care of her don't understand Parkinson's disease. And it's, so it takes this constant, this education. We need to figure out an efficient way to provide that.
Yes.
And probably some accountability that it's carried out.
Well, that to me is, one of the points of this format, to be able to share this information on topics that people are really interested in. And I know it's a little off topic, but if the rest of you have additional ideas about how to improve the education, not just of direct care work staff, but of course across the entire continuum as far as I'm concerned, we would certainly be eager to hear that.
Well, I think this is actually also true with any of us who are caring for a loved one themselves. We have good intentions almost all the time in those circumstances, and yet things can still go awry. Mostly it's because we didn't really know the right thing to do.
Exactly. And, it's impossible to know everything.
Right. So the support for caregivers to be able to use medications well, like making the decision whether to crush a medication or not, moving to having a good relationship with a pharmacist, doctor that you can really talk with about these things, or that has some way for you to get those questions answered, very helpful. And could probably prevent a whole ton of problems.
Ann, and Dr. Slatum, this is Judy.
Hey.
Judy.
Hi. I think it's going to come back to education and outreach, and especially with the assisted living and the nursing homes. And, of course, we are doing some of that, but sometimes we are, like with the Parkinson's Association, with the Alzheimer's Association, we do some outreach, but sometimes we're waiting for people to call us, Senior Connections and so on and so forth. But I think we're going to have to organize ourselves to go out into the community and offer education at little or no cost to some of the institutions. And at first, you might even be rejected there. I've been told in one assisted living, offering some education on hydration, basically, that they did their own education and they really refused it. So just starting to develop that model for, people in the community going into assisted livings and even into nursing homes and doing focused education on Parkinson's disease or dehydration or so on and so forth, skin care, all those good topics. But, that's what we're doing. And
well, I think that's actually a wonderful suggestion, and because I still am a believer that the individuals working in these direct care jobs want to do a good job.
Definitely.
If they know what they need to do and why, they can carry it out. Mm-hmm. They wouldn't be in a job where they take care of people if they didn't want to take care of people.
It's also
at some level.
Right, I think that's absolutely true.
Well, I think it's one of the ways that we can value these fairly low-paid workers. Now, not every worker is going to respond, but again, you have workers who are lightly supervised, not well paid, and who have had very little education many times. And, how well would we do in that setting? Little education, not much feedback, and not a big paycheck. So I really think that we have a lot of challenges with the workforce, but education is one of the ways that I've found in supervising nurses' aides that they feel more valued.
Yeah, I couldn't agree with you more.
Mm-hmm. Mm-hmm. I have a very specific question. Is it okay to ask specific questions about specific medications?
I guess depending on if it's real specific to a given patient, it's hard
to
do with. Okay.
Population.
Okay.
Yeah. I have a lot of clients have told me, generally it's older women, and we had the webinar on incontinence just last time. They stopped taking their diuretics, primarily Lasix. They stopped taking that because they say they'll have accidents. So it's prescribed, they're not taking it, and I see them and their ankles are pretty big, and, they say, well, they couldn't hold their water. So is there any way to take Lasix or any way to feed back to the physician either by breaking up doses or taking it a different way, or are there substitutions? I mean, how would you handle that?
Well, actually that's a common sort of therapeutic dilemma because of heart failure or other conditions, right? I mean, you need to get rid of the extra fluid, but incontinence becomes a growing problem. Sometimes it really takes getting down with that individual patient and working out a schedule that best fits their lifestyle. In other words, the timing of the day that they're taking it can be altered somewhat to fit around what they're doing. And then sometimes there can be alternative treatments that are non-diuretic for some health conditions. Depends on why they have the fluid.
Yes.
Okay. So that could be made better by some other medications with heart failure, for example. But if they have edema and they need to get rid of it, that's pretty much how it's going to happen. And, is with the medication. So it's a trade-off between the two things.
Well,
and so you can try changing the timing. You can try changing the schedule of the dosing, like you said, maybe lower doses at different times. Okay? I know I have some patients, they don't want to take it in the evening because they have to get up during the night, and that makes perfect sense. They don't like to take it in the morning because they want to go out and do something. And I have other patients who actually alter what time they take it depending on what's going on that day. And that's something they've figured out on their own. of what's going to work best for them.
Right.
And these little challenges are things that sometimes are hard to fix, so everybody gets frustrated with it. The doctor says you just need to take the medication. And, it's hard sometimes for them so they just don't take it because the other thing is more important to them.
Right.
Not having incontinence is more important than keeping the swollen ankles. Then I talk to them sometimes about non-pharmacologic. Are you using support stockings and some of the other things that can help with the edema?
Right.
It's not always just about the medication, and we try to come to some optimal solution. If it was a really, really important event on a day and you're just not going to take the medication that day, that can't be every day, or you're going to have edema in your ankles.
Right.
They have to work it around their life because they still need to live a quality life. Mm-hmm. And it's funny because what matters more to one patient is different than the next. Which of those things is the worst of the two?
Mm-hmm. And then what matters to us as health professionals is not necessarily
what matters to them.
No.
You're
I had
exactly
one lady
right.
tell me that. She said, I'm 93. I don't want to fall going to the bathroom, so I'm simply not taking it anymore.
Mm-hmm.
It made her hurry to the bathroom, and it was just more important for her to stay dry and not hurry. But as you say, possibly breaking up the dose, in that case.
Or the timing of the day.
The timing of the day, exactly.
Yeah, and sometimes looking at whether there's ways to optimize treatment otherwise, so that there's less need for the diuretic is another option that could be considered. And in the end of the day, the patient's going to make their decision.
Definitely. Thank you.
Yeah. I wish those things were easy to fix. And, it's the other thing, I guess, we didn't really talk about, but making sure they're not doing other things that contribute to that urge. So caffeine on top of Lasix can make that situation worse. Certainly there are other medications that can contribute to having incontinence. So a good review of the medications and the other things that they're doing lifestyle-wise. Well, if you skip the morning cup of coffee, then this might be less of an issue for you. Right?
Well, it goes back to what you said before, that, you have to take a look at the whole person and not just the collection of disease states. And it is a quality of life issue.
Yes.
Like Judy's pointing out, what is the most important thing to you? We can always make recommendations, but ultimately we have to respect people's autonomy in terms of what their preference is in terms of their own lifestyle.
And I figure, as long as we are making sure that they can be informed about the risks and benefits that go along with those decisions, they are their decisions to make in the end.
I think that's a very good point, and I also believe that this illustrates how we need to make sure that the person feels, or their advocate feels very heard in terms of what their priorities are. So for many reasons, but partly because then if they are heard, they will then be willing to hear the good points that you make about lifestyle changes and other ways to get to work through the need to take the medication, but also the need to have a quality life. I think a lot of times they're not feeling heard and respected. And I think, for example, how many old people have not lost someone or known someone who has died because of a fall on a hard tile in the bathroom? I think they have legitimate concerns about falling and that being pretty much the end. I myself have two women in my family, my mother and my aunt, who both died because of falls in bathrooms. I'm sure when I'm 80, I'm going to be very concerned about that, if not sooner.
Well, and you also bring up a good point about how do we help the patient and their caregiver to feel empowered to try to get these situations addressed in ways other than just not taking the medication, okay? And I try to encourage people to start making at least to write down their concerns, so that when they go to their encounter with their providers, it doesn't get swept up into something else that's on the provider's agenda. That there's a prompt to remind you to have this discussion. And writing it down, and also writing down some of the details. How frequent are these episodes of not making it to the bathroom? Or how burdensome, is this an everyday thing? Is it happening to me once a month? I mean, what is the compromise that I'm having to make in my lifestyle? And how important it is to me? If you jot those notes down, then you can actually say them when you get in the provider encounter.
That's right, and then the provider won't be labeling the person as non-compliant.
Yes.
They'll see them as a whole person who's willing to be an active problem solver.
Mm-hmm. And I've seen that work effectively.
Mm-hmm.
And I like it when my patients come to me with that, because I feel like I feel like it's good when they can be directing the need and what's going to come out of the encounter.
Mm-hmm. Well, you're going to... Say that again?
I said you're pretty special, though, Doctor.
Patty, we have a question from Christy. Christy, are you still on the line?
Can you hear me?
Yes.
Okay. I wasn't sure which one was mute for us here. At least here it doesn't say mute. Yeah, I was just wondering about physicians' barriers to, basically like lack of knowledge about medication interactions, or assuming responsibility that, or looking at medications as being the first cause, it seems like that keeps happening with different people that I know, patients that I know. The first look is never at medications, but yet it's a common problem, and it's a big problem that medication-related problems, are one of the ones that can solve a lot of other issues. So I'm just curious if you can speak at all to why that is.
I'd love to know why that is.
Yeah.
And it's not just physicians. It's even sometimes all kinds of encounters that go on in the health system that somehow haven't recognized the problem for what it is. And I think in one way it gets back to the education again. Mm-hmm. And I think in all fairness, I think it's pretty hard for a prescriber with a complex patient situation and a very short encounter time and little time to prepare for that encounter, mm-hmm. of what it is we're actually expecting them to accomplish.
What I'm wondering, too, like with a very specific issue with my mother, but and a separate one with a patient that I know, one of the common serious side effects listed in the patient information leaflet that is handed out that most people ignore, mm-hmm. and mm-hmm. just lay aside or just throw away, is right there. That whatever that serious side effect it is a problem, and noted in that.
That's where we have to become our own advocates, or the mm-hmm. advocates for those we care about or for, right? Mm-hmm. Because we're almost inundated with information. There is, every medication, if you look at the package insert, there are so many side effects and things listed there. Their actual direct relationship to the medication isn't always established very well. Mm-hmm. It was just observed in the clinical study at a higher rate than in the placebo group. Right? Mm-hmm. So,
and if you listen to all the side effects to all medications, you would never take any of them.
You would never take any of them. Exactly. So, but when a problem seems to be occurring, then trying to evaluate medications is one of the potential contributors. I find that when I talk with patients about raising that question, it's one of the things on their list. Could my medication be causing this? That it focuses the review on it. Mm-hmm. Or the encounter, so that question has to be answered. It might be answered as, I don't think so, and then the patient says, but it says here in this leaflet I got that it's a possible cause. Mm-hmm. So how would we know? It's learning to be an advocate for ourselves. And I think we've often been quite passive in our interactions with health providers, and health providers seem to be more comfortable being the ones driving the situation, and partly because of how they were trained. But that's going to be changing with baby boomers, I feel sure.
I'm seeing
that's
that.
Not how we're going to want. That's not
Yeah.
how we're going to want our encounters to be going, right?
We've, as consumers, we have information right at our fingertips if we're not, health professionals ourselves. And that's, how my mom found out about, hey, I'm not the only person with this problem, and wouldn't you know that a lot of there's 2 medication interactions happening here, and the very sudden onset of a problem. And, she informed her orthopedist, and he was like, I've never heard of that. Well, doctor, you might want to look it up. So
Exactly.
I see that happening, and I think you make a good point.
Well, and I feel as a healthcare practitioner, I can't know everything. I try to know as much as I can, and I try to listen, and I try to be informed, and I try to help people solve their problems. But sometimes I learn more from the patients, I think, than they learn from me. And it's a skill you have to learn.
I think that's an excellent point, Patty, and I think that this learning from each other that we're doing in these monthly webinars is really the point of all of this. And I hate to close off this discussion, but we are rolling up on 1 o'clock. So I want to make sure, are there any other quick questions or comments that anybody has? I want to thank you all for participating. Patty, do you have anything else you want to add in closing?
No, I'd just like to say thank you all for your comments and participation. We have a lot of work ahead of us, I think.
And we
Thank
do.
you.
Thank you. All in this together, though. So thank you all for being here. And just to remind you, this webinar will be posted on the website, and so you'll be able to have access to it later in the archives, and you'll be able to share it with other people that you work with. So that will be available, and you'll all be receiving a notice about the next webinar, that the topic is going to be durable medical equipment. So that notice will be coming out to you in not too long now. Nico, do you have any things you need to make sure we're aware of?
No, just that we'll be posting the recording of the webinar by this afternoon. So by late afternoon, you should be able to access it or have a link to it. So it'll be again free for all. So encourage everyone to stop by and listen in.
Okay. Thank you all. Thank you, Nico, for all your hard work.
No, thank you. Thank you all. Thank you again.
Thank you.
Thank you.
Everybody have a happy holiday.